Up until now, our focus has been on the physiological effects of multisystem trauma. Now we are going to delve into the psychological and emotional effects of trauma, and we're going to talk about post traumatic stress disorder. Here are your clinical objectives related to PTSD. PTSD is a mental health condition that develops after experiencing or witnessing a traumatic event. It is classified as a trauma stressor related disorder, and it is going to be characterized by persistent symptoms that interfere with daily functioning that occur for greater than 1 month. And these can include intrusive thoughts and flashbacks, things such as avoidance and hyperarousal. The pathophysiology or exact etiology of PTSD is unknown. However, it is suspected that PTSD is going to result from a combination of both structural and neurophysiological changes that occur in the brain. And we have been able to tell this based on imaging such as MRIs, where we can see differences in the brain between a person who has PTSD and a person who does not.
In patients with PTSD, the amygdala is hyperactive. And this is the part of the brain that is responsible for processing emotions, assessing threats, and activating the nervous system. Now, the hippocampus may be smaller and less effective in people with PTSD. And this is the part of the brain that is involved in learning and memory. So it may be harder for people with PTSD to make connections and form memory consolidation. The prefrontal cortex in people with PTSD, the prefrontal cortex may be less active. And this is the part of the brain that's going to be involved in your cognitive functions like your decision making, attention, memory, and impulse control. This is where a lot of your personality traits come from. Now, people with PTSD may also have increased responses to cortisol and norepinephrine to stress.
PTSD is a negative response to an overwhelming stressor, and it is believed to be a combination of both genetical factors and environmental factors. For example, those who are exposed to multiple or recurrent episodes of trauma or stress are more likely to develop PTSD. So, those in the military, firefighters, women or men in abusive relationships, molestations, victims of child abuse are much more likely to develop this than maybe someone who has only had a one time traumatic event. Roughly 7 to 8% of the population will develop PTSD at least some point during their lives. PTSD may be temporary or it could be permanent in nature. And about 8 million adults are going to have PTSD in a given year. And about 10% of women and 4% of men will develop PTSD at some point during their life. PTSD may elicit intense physical and emotional responses, where a person may experience the traumatic event over and over. And often we can see a combination of both physical and psychological symptoms. Like certain patients will have physical symptoms such as palpitations and headaches, and they may have those in combination with flashbacks, sleeping disorders, hypervigilance, irritability, avoidance, and this can lead to things such as substance abuse, depression, anxiety, and ultimately to suicide. There is no magic bullet cure for PTSD. In fact, treatment is usually going to be a combination of both pharmacological interventions and non pharmacological therapies, such as cognitive behavioral therapies. And when used together with medications, these behavior therapies have been shown to be more effective at treating PTSD. And often we will also see various complementary therapies brought into it, such as acupuncture and relaxation techniques. There is no specific medication to treat PTSD. However, SSRIs are going to be our first line agents at reducing some of the negative effects associated with PTSD. And the two FDA approved drugs for PTSD are going to be sertraline and paroxetine, and these are both SSRIs. Other medications you may see may be prazosin, and this is going to be an antihypertensive medication that is going to help treat PTSD associated nightmares. And although medications like benzos are used for anxiety, we generally want to avoid those in patients with PTSD because they've shown to have a negative effect.
Serotonin is your feel good neurotransmitter or your happy hormone. However, too much of anything in the body is never a good thing. Even serotonin. I personally would love just like one serotonin to be floating around in my brain, but whatever. Now, serotonin syndrome is usually caused by taking medications that directly or indirectly increase serotonin levels in the body. Now, some medications that directly increase serotonin will be your SSRIs, your SNRIs, your MAOIs, your TCAs, and some medications that can indirectly increase your serotonin can be fentanyl, certain antibiotics, such as Zyvox. Usually, serotonin syndrome is going to be more commonly caused by taking multiple medications that can increase your serotonin or accidentally or intentionally overdosing on serotonin increasing medications. And symptoms of this usually are going to start occurring anywhere from a few hours up to about 3 days after ingestion. And a variety of psychological, neuromuscular, and neurological symptoms will arise. A patient may experience anxiety, agitation, restlessness, disorientation. They may have neuromuscular abnormalities such as muscle rigidity, tremor, hyperreflexia, and they can have signs of autonomic hyperactivity, very similar to your like thyroid storm, and that's going to be your hyperthermia. Your pupils are going to be dilated. You're going to have very dry mucous membrane. Patients may experience significant tachycardia, sweating, and GI symptoms such as severe diarrhea and vomiting. And this can be fatal. So it's very important that you're aware of the signs and symptoms of serotonin syndrome so that you can detect this early on. Treatment for serotonin syndrome, first and foremost, stop the medication. I know with SRIs, you're always like, don't stop abruptly. Well, this is the one time that you want to stop it abruptly because you want to withdraw that source of serotonin. Patients with serotonin syndrome may develop very high fevers. I've seen a fever up to 108 from serotonin syndrome. So obviously you may want to treat that with antipyretics, cooling devices. Patients often are going to require mechanical ventilation. You may have to give them anticonvulsants, benzodiazepine, and for when you have the more moderate to severe serotonin syndrome, that's when you're going to give a medication that can actually block serotonin. And this is called cyproheptadine. Now, children are often going to present a little different with PTSD than adults. They may have a negative mood, they may be angry, they may have outbursts, they may become withdrawn, afraid, they may act reckless or aggressive and lash out. Adolescents, they tend to have a more similar course to adults. However, like in school and stuff, they may start exhibiting more destructive and disruptive behaviors. They may become more disrespectful to their peers, adults, and authority figures. And these adolescents are going to be at a higher risk for substance abuse, isolation, negative experiences in school, poor grades, negative health impacts, and they're at a higher risk for suicide. Older adults often present different too. They may often have more physical complaints like chest pain, palpitations, things like that, and less emotional and psychological symptoms. And it's also important to thoroughly screen adults for other signs of cognitive impairment, such as dementia. Safety is always going to be the priority nursing intervention. It is important to promptly assess the safety of the patient as well as those around the patient. And interventions are generally going to be aimed towards reducing anxiety, such as a calm and quiet environment, letting the patient know that they are safe. And sometimes pharmacological intervention may be required for those extreme symptoms. And you also need to be aware of the side effects of the medications you are giving, as well as some of the complications of giving these medications. For example, SSRIs, they can take up to 6 weeks to work, and the risk of suicide is going to be the greatest when first initiating these medications. Patients may start to feel happier, and at that time, they may be at their greatest risk of suicide. There are often many side effects related to sexual dysfunction, and that is going to be important to discuss this with the males, especially because a lot of times they are going to be non compliant when medications start interfering with sexual activity. Patients need to know to not stop taking these medications abruptly, to report side effects to their physician. Some of these medications can be hepatotoxic. So it's very important to be aware of all of these factors. And you also want to make sure that you're appropriately assessing for PTSD. You want to make sure that you are using evidence based assessment tools, assessing for risk factors, and addressing those immediate concerns. You want to make sure that you are being therapeutic, that you are establishing that trusting relationship, and that you are showing support to your patient. Here is an example of an evidence-based screening tool called the PTSD-5, which can help screen for PTSD. You will ask a patient a series of questions if they were exposed to a traumatic event. And if they answer yes to any of these, then you are going to ask some additional follow-up questions based on symptoms associated with PTSD that they may be having. That's all.